Welcome again. I'd like to welcome Ian Wright, who is a senior cardiac physiologist at Imperial in London. This is a high volume center who is very experienced with normality. The question is, what are the challenges and how are we coping with the new COVID pandemic? So please continue, Ian. I'll be very interested in what you have to say about this.
Thank you, Professor Lever. So I wanted to just go over some of the background to what we're having to do. Obviously, we're trying to keep patients safe in this current situation, and we want to also at the same time keep our patients safe. As far as is possible, because if that's not the case, then we're not able to treat them properly. Next slide, please. When this pandemic first broke out, it was immediately obvious to us that we had a lot of patients who were going to be extremely vulnerable. The vast majority of patients with an implanted device would sit in the population who need shielding. When we look at our device population at Imperial, we've got almost 2,000 patients who are over 80, and those are in a very high risk category. And we've got, from our pacemaker patients, an incredible number of patients over 90, 14%, and even 10 patients over 100. So these patients are very elderly, they're very high risk if they were to develop the pneumonitis associated with SARS-CoV-2 infection, and they would have a high risk of negative outcomes. The ICD population is obviously younger, but with a very high burden of disease. So most of our patients have obviously poor LV function, they have diabetes, hypertension, history of coronary artery disease. So that also puts them in a very high risk category. Next slide, please. We had a look at our rate of complications from COVID-19. We know that the expected rate of death in the ICD population is about 5.2%. That comes from a very comprehensive study of patients who died in the San Francisco area. And we have around 900 ICD patients that we look after. So we would expect figures of around 47 patients to die a year, and perhaps 4 a month if that was evenly spread through the year, which I appreciate may not be the case. So when we look at the patients that we have with devices, despite all of our efforts to try to aid with their isolation, we do have a number of patients that we know of who have succumbed to COVID-19. Next slide, please. So 14% patients in all we know are confirmed to have died from the condition, with a mean age of 82. And most of those have occurred in April, which is obviously the month so far in the UK with the highest rate of death. 4 of these patients are patients with ICDs. We also have 4 patients who've we know of who've had COVID-19 and are recovering. Next slide, please. In addition to that, we know of a similar number of patients with CIDs who've died from COVID, who have died who are not known to have COVID. And 7 of these are ICD patients, and 4 of those occurred in April. So if you take the ICD mortality, we've got probably double the expected number of deaths that we might normally acquire over a single month. So we can see that there has been an impact even despite what we're trying to do. Next slide, please. This slide shows some of these individual patients who've died from COVID-19, and the highlighted figures show you where these patients had a follow-up which was quite close to when they would have been developing the condition. And this is obviously what we're trying to avoid by going down a remote monitoring route as much as possible for these patients, because these interactions were opportunities both for the patient to acquire the infection and also for hospital staff to acquire it also. So this is the overwhelming thing that we're trying to avoid. Next slide, please. There are challenges in doing that, particularly for my particular centre. We have operated remote monitoring for a number of years, but certainly not 100% coverage of our population, and a much lower number of patients with bradycardia devices. We were beginning to roll out brady home monitoring, but it was in its relatively early stages. So we had to very rapidly accelerate that program. And I've listed here some of the requirements that we needed to do that. You've got to have the monitors to send out, and there was a supply issue to some degree at the beginning of the outbreak because so many hospitals were trying to do the same thing. We've got a range of devices of different ages in our population, some of which have relatively more or less home monitoring capability, and some of them that might require a different monitor. So we have to have the correct monitor for that patient. And we needed to get the agreement of the patient that they wanted to go down this remote monitoring route. We need to be able to send the patient the equipment either through the post or via some kind of courier service. And then we need the patient to set the monitor up. And that requires quite a lot of communication with the patient, which conventionally we would be doing face-to-face. And now we're having to do that over the phone, which introduces some difficulty. I've said here we need the staff to monitor and record the transmission, so we need to make sure that our staff are not acquiring the virus and having to self-isolate. And we also need the support from the IT department in being able to work from home. So ideally, we need to be able to access all the normal trust systems so that we can deliver the service without exposing too many members of the team at once to possible infection. Next slide, please. So once we've made sure that the patient is happy to receive home monitoring, which most of our patients have been very happy to, we need to register the device with the website. The ability of the device to send information requires the patient to plug it in, to do the initial setup, and to send a transmission when required to. And then we need to be able to review that. Next slide. An additional challenge that we've faced in this current situation is the ability to remotely monitor patients who are having a new device implant. Obviously, we've scaled back the invasive service greatly, so these are emergency cases. But conventionally, the patient would receive their home monitoring box at their first follow-up. And that obviously isn't going to be effective in the current situation where we're trying to keep them out of hospital. So we had to familiarize ourselves, those of us who work in the invasive side of the service, with the remote monitoring websites, know how to register the device and to enable the patient to take the monitor home with them at the end of the procedure. We set up a system for looking at the wounds from the device via email, and that's been working very effectively. So the patients are taking a picture with a smartphone, or someone is doing that for them, and then that's being sent via email, which is something that we wouldn't have done, and we would have been slightly nervous about doing previously because of the issues around patient confidentiality and dignity, perhaps. Next slide. There have been a number of issues when we've tried to set home monitoring up with patients via the phone system. Obviously, we've got to get them to answer the phone in the first place, but most people are at home at the moment, so there hasn't been too big a problem, but we have had some patients that we haven't been able to contact. Language can be an issue, and we've got a very diverse population in our area. We've got, as I've mentioned earlier, a high proportion of elderly patients, and that can introduce issues with communication. We know that a sixth of people over 80 are known to have dementia, and so that may be an issue with communication and trying to get the patient to set the system up effectively. Next slide. Finally, one of the things that I've realized, particularly since looking at the patients that unfortunately have died as a result of COVID-19, a number of these patients were having dialysis. Some of them were already in hospital, and so there's only so much that we can do with remote monitoring. If patients are having to come for appointments through the need for other services like dialysis, they're going to be exposed to the virus. And similarly, patients who are in hospital as inpatients are also exposed to the acquisition of the virus in the healthcare setting. Next slide, please. So that's the problems that we have been facing. I think a lot of people within our service and elsewhere are realizing that this situation provokes consideration of a number of potential opportunities. Next slide, please. And I'd like to start that by saying that there's a quote here: "We must acknowledge that those with the greatest health needs are also the most at risk of being left behind." And I think that certainly when this outbreak broke, my feelings were very much that the patients that we really needed to have on remote monitoring were actually a lot of the patients that we might not have offered it to. There may have been barriers to communication, particularly elderly patients, where there perhaps is a perception that they're not, they're challenged when it comes to using technology and maybe are not interested in home monitoring. And these are just the patients that we needed to be shielded. Next slide, please. But I think there's been a lot of positive outcomes in terms of the remote monitoring service and our vision for it in the future. We've had a lot of barriers that have been removed. So there are financial barriers to remote monitoring around remuneration, and there is a cost associated with it. And so we've been able to expand our remote monitoring service much more quickly than I think would have been otherwise the case. New staff, including myself, have been introduced to home monitoring. Some would say that was a bad thing, but overall, we've got a much expanded pool of staff who are familiar with the service. And I think it's helped to overcome some of the reluctance to offering remote monitoring to groups such as the elderly. One of the things that's been fed back to me is that I think patients feel an increased link to some of their patients, even though we're not now face to face. I think the fact that we are helping to shield these patients and we're communicating with them on a one-to-one basis over phone virtual consultations, we're actually seeing a different relationship develop than perhaps we did before. And probably one of the most important things is it started a dialogue about what should the new normal look like. I think everyone appreciates that going back to what we did before is not firstly possible in the short term, but also not viable in the long term. Next slide, please. This is a comment from one of my colleagues, Jamie from Birmingham, and he said, I think the rollout of routine home monitoring for all devices will continue after this. I can't see any reason why we would go back to how things were before. We now have access for staff to do remotes from home from their personal computers, whereas before this we had one work from home laptop. It's a game changer. And I think that echoes a lot of the feeling that I've, a lot of feedback that I've had from our staff as well as staff from other hospitals. Next slide, please. And I think he also commented on how high patient acceptance is of this technology. When we ask patients, there is only a very small number of people who would be reluctant to take it up. And certainly they have been given an example, a demonstration of how useful this technology will be to them in the future going forward. Next slide, please. So in conclusion, I'd like to say that remote monitoring is currently seen as complementary to in-clinic follow-up. Next slide, please. And from this pandemic, I think we should be moving more quickly than we would have done otherwise into the future, where in-clinic follow-up becomes complementary to remote monitoring. So that is how I would see the future developing. I think that was going to happen over time, but the pandemic is pushing us closer towards that situation where we see patients on home monitoring and we only see them face to face when there is a need to do it. Because currently we're running two almost parallel systems of home monitoring and in-clinic follow-up, which duplicate a lot of activity. And really we need to be moving towards this kind of targeted approach where we're seeing the 20% of patients who actually require some action or clinical evaluation and optimization of therapy. So I can leave that there and see if Professor Laver has any questions or comments.
Thank you, Ian. That's a very comprehensive account of your experience, which mirrors our experience as well. I mean, clearly we're in a new age of remote monitoring. Over the past 15, almost 20 years, actually, we've been comparing home monitoring to clinic. And by and large, with the exception of one study, that has not been shown to reduce hard outcomes. And there's been quite a lot of talk about the number of false positives, and it is not without, as you mentioned before, cost. However, this is a completely different thing now. There is no follow-up, physical follow-up. There has to be a reduction in the number of visits that patients have. So, you know, this is a completely different ballgame. I mean, whilst patients, there's no doubt that patients, the majority of patients, like it. I do wonder about the number of false positives. If we have some devices with some algorithms or lack of them, and we have unselected alerts, the number of alerts is huge. How are you managing to filter those?
Well, I think that is always a problem with current technology. And one of the things that concerns me a little bit, because we have a team of home monitoring physiologists who are excellent and very dedicated. We are expanding the number of patients very rapidly who are on home monitoring. And it does concern me whether that will become a difficult number of patients to cope with moving into the future. So at the moment, things are okay, but if we're increasing the number of home monitoring patients exponentially, we might reach a problem where those alerts become very difficult to cope with in terms of numbers. Obviously, one way of doing that is if we reduce the in-office visits, we can expand the number of staff who are doing the remote monitoring. So I think one of the problems we've had over the last 10 or 15 years is that we've been trying to maintain two parallel services rather than move to one as the main model of care. So we've been having home monitoring and face-to-face follow-up running so much in parallel that we're duplicating resources. So I think there are a number of ways in which we can deal with the alert situation. One is by reducing that face-to-face need, but also the technology is also improving, and things like heart failure alerts are going to be improving in terms of their specificity going forward. I think we were burnt a little bit by things like Optivol, but the newer model of multi-parameter alerts is going to be a lot more specific, and that will help to reduce the number of false positive alerts.
Yeah. One last question. In those patients who died from COVID, have you seen, even anecdotally, any changes? I mean, these patients become tachycardic, they can have changes in thoracic impedance, and you would expect that some of these multimodality variables may change. Have you seen any examples of patients who have flagged up with positive heart failure variables, for example, and who have subsequently died?
So this is something that we're looking at. At the moment, the number of actual remote transmissions that we have from patients who've died with the condition is quite small. So at the moment, we don't have enough data to be able to make conclusions from that yet, but it is something that we're looking at, and I think there may be potential for looking at that data to see if it has any value in the management of the condition. Unfortunately, a lot of patients, if they come into hospital, if they're admitted, they generally don't take their home monitoring box with them, and so we're often not getting the data that would be useful in that context. But I think it's something that we're definitely looking at.
Excellent. Well, thanks, Ian, for a very nice presentation. It certainly puts things into perspective, and it also shows that you're going through the same issues as we're all going through. Thank you very much indeed.
Thank you very much.